Well, good afternoon, everyone. Thank you for joining us on this Friday. Brandon Garrett, the National Minority Quality Forum. And as you know, it's on Fridays. Friday, I say we like to edutain and talk about some important topics in healthcare. Today's panel is called Seen, Heard, and Fighting Back, a webinar in commemoration of National FSGS Awareness Day 2026. It will be led by NMQS very own Dr. Britt Weinstock. I've known Britt since working on 2006, the CDC budget talk, and she was the health policy budget lead, a priority lead. She graduated and she worked for Dr. Christensen at the time. She is a graduate of both Bucknell and Howard University, where she got her PhD. And so there's no person better or more educated on this issue than Britt. So I'll let her go ahead and take over and lead this discussion.
Thank you, Brandon Garrett. Good morning, or sorry, good afternoon, everybody. I'm Dr. Britt Weinstock, and as Brandon said, I'm with NMQF, with the Center for Public Policy. Thank you very much for taking today, Friday, to join us for this webinar on FSGS. It's focal segmental glomerulosclerosis. I will let Dr. Hall get into the specifics of that, but essentially this is a rare kidney disease that just hasn't received as much attention as it should have. I hate that they call it rare because in the African-American community, it's actually not that rare. African-Americans represent 14% of the US population, yet 60% of all diagnosed FSGS cases. And this disease is very aggressive. And it typically affects everybody, but it affects people often during their most productive life years, which is a devastating diagnosis to get when you do get it. And it's also worth noting that, with other rare kidney diseases, FSGS accounts for roughly 60% of all kidney failure cases in the United States. So what we're trying to do with this webinar is not only commemorate National FSGS Awareness Day, which I believe occurred a few days prior on June 9th, but it's in the spirit of that, but also to ensure that the audience is aware that the FSGS is a problem. It's a health equity issue that's been under addressed for far too long. But the good news is that with raising awareness and increasing surveillance and increasing screenings, we can start to change the narrative. And then there's so much going on in the treatment space that also is really important for the audience to hear about and learn about today. And then just obviously what's happening in policy, and we have Matt Johnson from NEFCure to update everybody on that. So, the story on FSGS started off it was grim, and the story is changing. It's being rewritten as we're talking right now. And so this whole webinar is to ensure that all of you are a part of that narrative and a part of that story as it continues to unfold. So without further ado, I know we have a short time period. We've got 3 panelists. We've got the first person you're going to hear from today is Dr. Jensen Hall. He is in the nice bow tie. A nephrologist, a researcher, a leader on FSGS and other rare kidney disease issues, and also an educator. I think he's on faculty at Duke University. Followed by him, we will have Mr. Destin Fuller-Hope, who is, I think, just a rock star. His story just almost brought me to tears. He's a filmmaker and a storyteller. He's also someone living with FSGS, and he received a kidney transplant. So his story, I think, is really gonna hit hard about what FSGS looks like to someone who's living with it, and his struggles, I think, will really put a lot of this into a really appropriate context. And then rounding out the day, we have Mr. Matt Johnson from NEFCure. I've known Matt for a long time. He is a rock star in this space. He is a passionate advocate. He's got political savvy like none other. And so he keeps what's happening on the policy front at the federal and state level on point as it relates to what's happening in the FSGS space, as well as the rare kidney disease space. So I'm really pleased that all 3 have agreed to join us today. And so I'm going to get into it. So, Mr. Fuller-Hope, I know you have a 5-minute video that you want to share with us. Your work, I know it's award-winning. So if you would open it up, and we'll watch it. Thank you.
Absolutely. I'll share my screen right now.
you have volume? Destin, we can't hear the video. I don't know if anybody else can hear it.
Here,
Oh, okay. One
you're
moment.
allowed to take a breath.
Let me know if you can all hear this. Are we good there?
No, I can't.
am deserving of
I heard deserving.
Oh, you heard it. Oh, okay, one moment. Then I just need to mute myself then. Okay. If you can hear that, then it's my mic that's in the way. Okay, here we go. Let me know if you can still hear or can't hear.
No.
All right, slight technical difficulty, but let me sort of work on this. I don't know if you guys want to move on from here because I don't want to waste everyone's time. But I'll try and fix this if you guys want to move forward.
We'll move forward. And if you can fix it, that'd be great. We can have it at the back end.
No problem.
Okay. All right. So, Dr. Hall, I know this is a little bit earlier than you thought you'd be speaking, but I know that you're very well prepared. Just I have some time to talk about you and sort of brag on you a bit. You and I spoke, and Dr. Hall is someone who has very rare, I would say, very rare and invaluable perspectives to offer. He's not only a clinician, but he's also a researcher who has spent his career on the front lines of kidney disease, including FSGS. Your awards and your academics, the alphabet after your name is far too long to go into detail about, but your bio is included. But Dr. Hall is here to speak about what he sees on the front lines as both a clinician and also a researcher. And I also hope that there are some practical recommendations that you will walk away with in terms of what everybody can do to become more aware and engaged, what people who perhaps are at risk can do to become more vigilant about their health, and then also what we know is happening in the treatment space. So, Dr. Hall, I will turn it over to you.
Thank you, Britt, and thank you to National Minority Quality Forum for making this opportunity available. It's an honor to be able to contribute to the conversation, and especially on this topic, which for quite a bit of my training experience was one where we were positioned mainly in hope. We hadn't really realized many of our objectives, particularly in terms of therapeutic translation of our research. But now we're seeing a lot of that come to be. So it's a very hopeful time. I can do my presentation if you can start the slideshow.
Sure. Dane has your slides.
All right, perfect. So my goal in this is really just to, in some ways, summarize some relevant aspects about the biology of FSGS as we understand it currently. Really, not so much to take you through medical school, but to just give you a sense for how our therapies and our understanding of the process have kind of influenced not only the way we understand the problem, but what we ultimately are able to offer patients with the issue, both in terms of therapeutics, but also in ways of reimagining life experience with this problem, particularly as it might relate to other members of the family. There's a real appreciation in my work for the familial nature of the disease, and so I'm hoping to share some of all of those elements with you. Next slide, please. Okay, these are my disclosures. And I thought it might be helpful to just start with some common language. We've been referring to focal segmental glomerulosclerosis in a way that, almost assumes that maybe people know what we're talking about. Each of those words is very relevant to a histopathologist, the type of person that would take a biopsy sample of the kidney and then look at it under a microscope and try to describe what they see. These words are more or less their description of what they see. So when you say focal segmental glomerulosclerosis, what you're referencing is the tissue change. And what you're saying in particular, as you look at this image in the upper panel, you see two glomeruli, which are the filtering components of the kidney, off to the left and to the right in the bottom corners. Those are relatively healthy for the most part. And by comparison to the third that's positioned in between them slightly higher up, there's a large area of pink. That's a lot of scarring. So that's the glomerulus that's sick. That's the one that has this manifestation of scarring that we refer to as focal segmental glomerulosclerosis. And what each word means in actuality is intended to reference is listed below. So focal sum, segmental sections of some of the glomeruli, which are the filters of the kidney, are scarred. Okay, so a lot of language to just more or less boil down an observation. Now, there are plenty of ways that you can end up with this lesion. It's not just one lesion meaning one problem. You can get here a number of different ways, but once you're here, there are certain things that must be considered, particularly if it's a process that's starting when you're young. So I wanted to kind of familiarize you all with language, let you know how practically it's intended to describe a lesion, and that most of the ways that you can come there are sort of still in the development in terms of our understanding. Next slide, please. All right. So just some general factoids about FSGS. This is the most common primary lesion of the kidney filter that can cause or lead to end-stage kidney disease in the United States. But this is a worldwide issue, more so in the United States and other developed parts of the globe than others, but certainly here. It manifests clinically. When we see it in the clinic, what we're seeing is what we call steroid-resistant nephrotic syndrome. And we also often see this progressing rapidly towards to end-stage kidney disease. So what does that mean? Yet another classification, steroid resistant, meaning you can't really treat out of the problem or get the problem under control with steroids. Sometimes you have to go to other forms of therapy, and that usually suggests something different about the nature of the disease, as opposed to other forms of glomerular disease like minimal change, which is fairly amenable to steroid treatment. FSGS tends to be resistant. That's why we characterize it in that way. Most patients will progress to end-stage kidney disease within 5 to 10 years of diagnosis. That's important because if you're talking about, the importance of early detection, you really want to know as soon as you can possibly know what you're dealing with. And this is the type of diagnosis that can only come about by biopsy. And so, if you're seeing, this is for primary care physicians or people in other quarters other than nephrology that may be coming into contact with patients that you might be concerned for because of things like high blood pressure, protein in the urine. It's not the time to sit on that and wait for it to get better. Referrals to nephrology are best done when they're early so that we have as much time to be helpful as we possibly can. Frequency of new cases has increased over the past, increased 13-fold over the past 3 decades. Much of that, can be attributed to kind of idiopathic causes of the injury. We don't quite know why, but we know what it is. And it can be all sorts of environmental factors driving it. There are plenty of different ways to get there, as I said. But this rise in the prevalence has been concerning and focused our attention really on how we can get not only a better understanding of, but a better means of treating the disease of people with it. Unfortunately, this disproportionately affects people of Black, African American ancestry. Although anybody, in the diaspora can fall into that category. So it's really important for people to rethink what they know about themselves and about their family histories. You can't really grade it or gauge it based on your physical appearance. It really is about your ancestry and what that says about your genetics, your predispositions, and so on. In general, this situation, this process of scarring has to do with some initial insult or injury that the specialized cells of the kidney filter experience. Those cells are specifically referred to as the glomerular visceral epithelial cells, but because of their appearance, they look like little octopi, with projections. They've taken on the name podocyte because those projections look like little feet. So that's how I'll refer to them going forward. Next slide, please. So what is it about the podocyte that is so important, and why is it, kind of the center of all things FSGS? What causes FSGS? And as I mentioned, injury to the podocytes really sets this up. The podocytes are cells that negotiate the barrier functions, if you will, of the filter. So when we think about filtration mechanics, you're talking about the blood running over, which is essentially a sieve or something that works like a sieve. And that sieve is made up of multiple layers. It's both kind of protein understructure and cell components. And that makes up that filtration barrier. The podocytes are really important, a critical part of not only making up the filtration barrier functionally, but they restore it. They make proteins that help to construct it. And so you can imagine that if those cells become injured, as they function less well, the filtering functions of the kidney also function less well. The things that can cause podocytes to be injured are many and vary across the spectrum. It can be drugs, it can be systemic infections, it can be genetic causes, many different things. But however you arrive at injuring the podocytes, the usual sequence of events is that podocytes, in response to that injury, focus their efforts more on attachment to the basement membrane, which is the surface where they make contact with the what would be the filtration barrier. And sometimes they will lose their attachments to one another, which is really crucial for the filtering work that they do. When that happens, that leaves open a lot of space for things that shouldn't normally get through the filter to get through. Things like proteins, especially smaller proteins of a certain size like albumin. That's one we follow in clinic. So one way that we can know that podocytes are injured, part of that is to see proteins in the urine. So you'll hear your doctors paying a particular attention to that and how that particular finding is progressing as your disease course advances. So what we really want to do is try and protect the podocytes as much as we can. We know that we're being successful in that, or believe that we're being successful in that, when we can see levels of protein in the urine drop. And so that's the significance of that as you enter discussions with your provider about this disease and how they treat it. Next slide, please. So as I mentioned, podocytes really negotiate this filter. And here's a better image off to the left. You can see that the podocytes in yellow are wrapped around this sort of red tubing. That's meant to be like a capillary loop. And your filter, your kidney filter apparatus is basically a loop, a tuft of these capillary loops, and they're all enshrouded, wrapped around by these podocytes. The podocytes connect themselves or attach themselves to the outside of the capillaries, but then they make contact with one another by these little foot processes, those feet that I mentioned earlier. And what you can see when you really zoom in closely, between the feet of different podocytes, you're actually seeing the little proteins that span across that space between the feet. And that laddering is what gives you a lot of the filtration, the ultrafiltration effect that you want in a healthy kidney filter. It keeps things on the blood side that the body needs to retain, like the albumin protein on one side, but it allows for other things that are smaller and that can pass through, salts, waste products, and whatever, to get through the filter so that they can ultimately pass into the urine. When podocytes fail, this whole system, this really fine ultramachinery breaks down. So that barrier goes away or deteriorates. And what you end up losing are things that were intended to stay on the blood side that will now end up in the urine. And that's how we both detect the problem clinically, but also what we have to treat in order to stave off the worst outcomes. Next slide, please. So what does FSGS look like? And I'm actually pulling this slide from another deck where I used to speak to people about a particular form of FSGS, one that's come to prominence more recently in the past decade or so with new understanding about genetic causes of kidney disease. Here I'm referring to a variant of FSGS, if you will, called apolipoprotein L1 mediated kidney disease. So APOL1 mediated kidney disease is driven by the expression of genetic variants in the APOL1 gene. This gene is originally intended, everyone has it, but it's originally intended to be helpful in the immune system, fighting off certain forms of infection, parasitic infection. But over the course of time, as certain adaptations had to be made to more adequately ward off the threat of certain parasitic pathogens, we rearranged our genetic code, particularly people of African descent rearranged their genetic code. So by that I mean people living in West Africa, Sub-Saharan Africa, in 200,000 say years ago, when they encountered the threat endemic to that region of African sleeping sickness carried by the tsetse fly. They had to rearrange their the sequencing of that gene so that that protein that would ultimately be produced by that gene offered them protection against that pathogen. And they did that. But at the same time they made those rearrangements also predisposed them to kidney disease for reasons that we are still coming to understand. But it's very clear that people from that region of the world, or at least that have their ancestry positioned there, that now are kind of distributed all over the globe through the diaspora, have a particular risk for kidney disease related to those original changes in the genetic coding that were intended to be protective. So when we see this, what does it look like? So you'll see it in people of African ancestry. It commonly shows up in people that are 15 to 39 years of age. Again, a reflection on why early detection is so important. It commonly manifests as FSGS, but it can show up as hypertensive nephrosclerosis. So the point is that we have to be very thoughtful about the patients that we're encountering, understanding the phenotype, and maybe how it might differ between people. But there are certain common features that you just want to be aware of. You can see it in young people as early hypertension. You can see it as protein in the urine. These are not things you want to ignore or pass by. You want to be aggressive about it, if only to rule out a problem like this, particularly if their history and the phenotype kind of presents them as being potentially at risk. It can be a silent disease. Typically it is in most forms of kidney disease. And, in that regard, it will advance quietly in the background until you run into things like maybe a screening exam for insurance purposes or for work that say, oh, you have a problem. So it's not something that's going to yell at you like a broken leg. This is going to be something that creeps up on you. And so it's very important to know early what the threat might be. The only way you can know at this point if you have APOL1 mediated kidney disease is to have a genetic test. We have to actually see the sequence of the gene and to know that you have the variants in the gene. The high-risk condition is when you have variants in both copies of the gene. You're going to have two copies of the APOL1 gene, one from mom, one from dad. If you have variations in the sequence in both of those copies, you're considered high risk. Doesn't mean you'll always get the disease. A second hit is required. So you have to have the genetic variants, but then also some other instigator. But if you have that, then you might get AMKD, and we need to be aggressive about how we evaluate it and treat it. APOL1, obviously, because it's genetic at its basis, can run in families. So as a representative of a family group, you, the one person in clinic speaking with your doctor, you need to take what you learned back to your family and talk to them about the risk that they may have based on what you understand about your own. There are ways to find out about this and get your genetics sequence or genetic or your genotype uncovered. There are screening opportunities. I am affiliated with the Glomtown Foundation, and we offer in our Embark Awareness program free education primarily and screening for not only APOL1, but other forms of genetic kidney disease. But the intention is to pair people early with education, awareness about their own status, and attention from nephrologists. And there's opportunity to learn more about Embark if you visit the website that I've included down on the bottom. Next slide, please. So here's some hope on the horizon. I mentioned APOL1 mediated kidney disease as a form of FSGS, but it's not all there is to it. It is a genetic form, but as I said, there are multiple different forms. But just still focusing on AMKD to just show how much progress we have made in just a little bit of time we've really known about AMKD. There are clinical trials ongoing right now. And this little kind of octopus-looking thing is, of course, intended to be the podocyte. The trials that we are investigating are testing drugs that approach the way that the podocyte makes the APOL1 protein in multiple different ways. The understanding is that if you can reduce the amount of protein, the APOL1 protein that the podocyte is making, that potentially you can stave off the bad effects of the protein in the podocyte. I won't go into too much about how the APOL1 protein works and the damage that it does. Maybe if questions come up, I can elaborate. But needless to say, the goal is to get the level of the protein down or to stop it from functioning. If we can do that, we can reverse the injurious effects. And we've actually seen in some of these trials early evidence that these drugs are meeting the intended objective. And so that is very encouraging. I encourage you, if this is if you have a concern about this for you or for your family, if you have been genotyped and found out that you have the high-risk genotype for APOL1, consider the opportunities that are available in these trials and probably more to come to involve yourself. Speak for the group of people that are most at risk by being active and being a part of these clinical trials. The only way we're going to get information that we need to know about how to treat and be effective is if we have participation from the highest risk populations. So consider that. It is a service to yourself, obviously, but also to the broader community. Next slide, please. Aside from the progress we're making in APOL1 directed clinical trials, we've also had the first approval of an FSGS drug. This was mentioned earlier. I believe Britt mentioned Filspari as a drug recently approved by the FDA for the treatment of FSGS. What I'm showing you here in the panels is first some study data from the DUET trial, which is a phase 2 trial. It just showed that when you compare Filspari or sparsentan to irbesartan, which is sort of an ARB, a standard of care component of therapy, at the maximum dose of irbesartan, which is not always where we're able to get patients due to tolerance and other reasons. Even when it's at its most potent and at its strongest, it still couldn't do for the reduction in proteinuria what Filspari was ultimately able to do. And those data were actually shown in to be maintained in the follow-up trial, the duplex study, that looked at a larger cohort of patients over a much longer period of time. You can see that the bottom darker blue line is proteinuria reduction with Filspari, and that is in patients with FSGS, more or less all comers. The important thing I want to point out here, I've been mentioning to you, FSGS, you can get to that lesion by multiple routes: genetic, systemic disease, and others. This drug was helpful across the spectrum. So there are patients with genetic disease that actually responded with reductions in proteinuria buried in this cohort. And so that's really, really promising information for a person who focuses on kidney genetics that way. It's very encouraging to me to know that there's a drug now that could be helpful to people with so-called hardwired genetic disease. It is not only the first as a dual mechanism of action, it is very specifically protective to podocytes and their function. It significantly reduced proteinuria, as I mentioned, compared to a max dose standard of care therapy. And it's actually also been shown to be effective in IgA nephropathy. which is another form of glomerular disease, not that we'll discuss today, but still very important. So we're making a lot of forward movement in a very short period of time. It's a really hopeful thing to be a nephrologist and to be a kidney patient at this point. Next slide, please. All right. So in conclusion, the things that I'll say, FSGS is complex. It's an irreversible kidney lesion. Once you've had that scarring to your glomerulus, you can't really undo that scarring. But if you can get to care early, you can protect the kidney function that you have. You can protect the remaining architecture of kidney that you have in ways that we were better able to do now than we were just even 10 years ago. Advancements in our understanding of rare and common genetic injuries and podocytes have informed our understanding of the disease mechanisms and help us to test more targeted therapies. Clinical trial participation is so important, particularly for at-risk groups. So for people that might be at risk for AMKD, no one else can enter the trials for AMKD and give the answers that we need but you. So we need to think differently about clinical trials, our participation, our willingness to do so, and also about discussions with family about our own personal health history and how it might relate to theirs. Early diagnosis and treatment is key. I tell my patients all the time, time is kidney. I mean that in the sense that the earlier you can get to us, the more we can do to be helpful. I mentioned the first targeted therapy, very hopeful outlook on the horizon, because if we can understand one drug that can treat both genetic and non-genetic forms of disease, that's hopeful for the future of potentially learning others and expanding the repertoire in the near future. I would just say as a final note that future investment in research is critical. What we've been able to accomplish up to this point is all based on the countless efforts of researchers across the spectrum, people interested in kidney disease and people that are not, but just have an interest in processes that still bear relevance to the kidney and its function, have all come together to produce all of this forward progress. We need to keep that going at every level that we can. I think that's my last slide. Maybe you can advance to make sure that I'm correct. And I look forward to questions. Thank you. Yeah, that's a reserve slide. Those are all reserve slides. Thank you.
Sorry, I was not able to unmute myself because the host said I couldn't do so. So I apologize. Dr. Hall, thank you very much for that presentation. There was a lot to unpack. We're going to keep it moving, but one thing I want to throw to the audience that you said that caught my attention was that folks who may have FSGS and don't know it, when they go to a doctor, it may present as something like hypertension. And no one ever makes those connecting dots. So I wanted to throw it out there because that is a big part of the lack of awareness around this condition in particular. The other thing I want to throw out too is when you talked about how aggressive it is and how it affects people in the younger, most productive life years. That's another key point. But I'm going to segue that into our next panelist. That's Mr. Destin Fuller Hope, who can speak better to this than I can. But I wanted to sort of frame the stage that way as we pass it off. So, Destin, it's yours.
Okay, couldn't unmute myself there for a second. Same problem you had, Dr. Weidenstock. But yeah, thank you for giving me the floor. I'm going to speak on my experience, as someone who's had FSGS and not really having the understanding of, what it really was or how it affected me or how it affected the community in that way. I've been living with FSGS since I was 18. I was diagnosed a couple of days before I turned 19. And I'm currently 31, so it's been some time. And I've had a transplant, so I'm much better now. But I had a transplant at 25 and was diagnosed at 18. When I was 18, close to turning 19, I was in college. I had spent a year in school, and I had this summer job as a camp counselor, and over that summer, we used to take the I used to be a camp counselor for second grade boys. And part of my job was I took the boys to the pool every twice a day. And it was a strangely cold summer morning. And I went to the pool and I came out and I completely forgot my towel. And I was really, really cold. And I ended up getting like a cold, like a sign of some sort of infection. And it lasted for about 2 or 3 days. And on that second or third day, I woke up from a nap and my legs were completely swollen. And I did not, just like that, within like 48 hours. And I did not know what it was, but I just sort of, I just brushed it off. And I just thought, I don't know what this is. I kind of sort of fell asleep in a chair, so my legs were hanging down. I thought maybe it's just the waterway. I don't know. And eventually it just got worse and worse. And I didn't know it at the time, but I had pitting edema. And it was so deep, if you put your finger in it, it would be like a quarter inch thick. Like it was incredibly, incredibly noticeable. And a friend, my closest friend in life, his mother was a nurse. He and I worked the same job. She used to drop us off at that job, and she goes, you need to get that checked out. I think that has something to do with your kidneys. And she spoke to my mom about it, and she took me to this nephrologist that was no more than a mile away from our home. And sure enough, my doctor, he did some blood work. I'm not thinking too hard about it. I think somehow it'll disappear because I'm just this very optimistic 18-year-old, like, it'll be fine. And he we scheduled another appointment after the blood work, and he goes, so you've got a rare kidney disease called focal segmental glomerulosclerosis. And I'm like, it goes clean over my head because I don't know what he said. My only concern at the time was, can I still keep playing sports? I have no clue what this nephrologist just told me. I don't understand the weight of it. I'm thinking maybe it's curable. Is this, I just don't understand. And he goes, yeah, you're at stage one right now. And I go, what does that mean? Am I okay? I feel fine. And I felt great. I felt perfectly fine. He gave me some water pills some diuretics to get rid of the pit and edema. That went away. I thought I was fine. And he goes, well, we sort of have to keep an eye on it. And I keep asking a few more questions, and he's sort of talking around it and not really telling me the weight of the situation. And I look back on that thinking I just didn't know what part to listen to because I had never been in this situation with a doctor. The doctors understood much more than I did. But knowing what I know now, and what we all know now, is that even that nephrologist at the time also did not know because FSGS was so understudied. And my only concern was, can I keep playing sports? At that time in my life, although I was in college, I was training to play professional tennis. And I've been training for the previous 5 years and spending every ounce of my day training for that. And so I was diagnosed with this kidney disease and I still felt fine. And I thought, I'll just keep living my life, not really understanding. My parents had all the questions, but truthfully, I didn't know what to tell them because I didn't really understand what the doctor had told me. And what I told them was, I've got this kidney disease apparently, but I seem to feel fine. They said they keep an eye on it. And that's kind of all I really know. I just know it's rare and it's very complicated to say. And as I am gearing up for my very first professional tournament, 2 to 3 months later, after my diagnosis, I still feel fine. No pharmacy near me no longer carried the diuretic that they were given, that was given to me. And I couldn't find it. And every pharmacy I called, they just magically didn't have it. And in the week and a half time, 2 weeks that I couldn't find this diuretic, all the water weight, all the pitted edema returned and more. And in the 2 week span, I gained about 30 pounds, never understanding where it all came from. And it began to hit me what that kidney disease began to mean. I end up in the emergency room. They give me diuretics directly. They find a pharmacy 3 towns away that happens to be carrying it. And I get it back. And they get a lot of that water weight off, but it doesn't really come off all the way. And I'm thinking, this is so odd. I go to the gym and I'm playing these sports and I realize I can't go play this tournament that I want to do, that I trained, my whole life to begin this, journey as a, professional athlete, thinking, okay, well, I guess I'll just wait for the water to come off again over some time and I'll go. And it just kept piling up and piling up. And before you knew it, I went from 190 pounds to 230 pounds. And then within a couple of months, I was 240 and then 250 and then 260. And I went from stage 1 to stage 2. And that's when I began to feel the effects of FSGS. That's when I started to ask more serious questions to my nephrologist, like what is happening with my body? And what is happening? Like you just need to explain to me better. Explain to me like I'm five. And what he essentially told me is he re-articulated himself. And he said, you've got a rare kidney disease and it's not really going to go away. The most we can do is keep an eye on it and try to manage it. And we're going to give you all these medications and we're going to try and keep the protein out of your urine the best we can. But the truth is, I don't know what's going to happen next. We can try and keep it at bay, but eventually, you get to the next stage. And while he's telling me this, I'm realizing I'm always short of breath. I'm sleeping very poorly. My stress is unusually high. I can't walk up and down a flight of stairs without being out of breath. I don't fit any of my clothes. And I'm not really, I just feel physically terrible all the time. And I'm still not, I have even more questions based off what he's told me. But some time passes and I go, well, I hope this, goes fine. And at this time, I realize I can't play my favorite thing anymore. I can't play tennis. I went to school. The college that I picked, I went to strictly because I had a great tennis team. It was a Division I school. My whole day, life, year, month, minute to minute of the day was scheduled around this one thing that I can no longer do. And after about a year of living at stage two, I realized I'm not going to play this sport anymore. The thing that I had worked for is not going to happen because this kidney disease is not going away. And it's not being kept at bay either. It's slowly advancing. And I'm sitting in this limbo. I took a year off of school. I went to a community college to save some money if I wasn't going to play on that tennis team anyway. And I had goals to go to community college anyway for a year so I could transfer to another school in California and play for a different team. In that period is when I got sick, and in that period is when I decided to take an extra year off. And that one year at community college eventually became 1 year off of school altogether. And in that limbo period, I eventually hit stage three. And now there is a point where I've got, water weight almost beneath my eyes. And it looks like I have these giant bags. I'm about 275 pounds. And all my family and friends are whispering, what happened to Destin? What happened to him? He just doesn't look the same way he did a year ago. Did something happen? And it's this weird thing in my family where they're saying it, but everyone's whispering. And it's this thing that feels invisible to me because when people did ask me directly, I didn't really know what to tell them because I didn't have a clear answer. They look at me like there's a physical difference in you, but you're not really missing any limbs. It's not like you have a terminal illness, things that most people can understand. I could understand if you come back and you're missing an arm, you don't have to explain anything. But having FSGS is like this invisible thing that ravages you from the inside. And people don't really understand what's going on. And even you don't really understand what's going on. You can only really tell people how you feel. And but because they can't see much, they can't really see any real visual evidence, they kind of don't really know where to place you. So at some point I leave school altogether and I don't know what I'm going to do with my life. And I'm no longer playing tennis. And I've got this disease that's at somewhere in the middle of stage one and stage five. I don't know what the next stage brings. And I'm really wrestling with my mortality. My weight keeps going up and it's beginning to hit me. And at this point, I'm no longer 18, 19. I'm about 22. And I'm taking life a bit more seriously at 22 than I did at 18. And I'm wrestling with the idea of, is this supposed to, how does this go? What's the end result of this? I didn't think ahead, and nor did my doctor tell me what really happens if the stages keep going. And at this point, we're 2 or 3 years in, and my family still doesn't have any answers. And again, neither do I. And I am taking every medication under the sun. And they tried everything. I used to take, they gave me prednisone. They gave me 60 milligrams every day. That didn't work, so they gave me 120 milligrams every other day. They stacked it on top of four other medications I can't remember. They gave me a shot at some point I used to have to take every day that I was terrible at. I used to go to my nephrologist's office and have the nurses there inject me because I couldn't do it. And I'm on like 4 or 5 medications. And at some point, I remember trying to re-enroll in my community college. And I had this gallon Ziploc bag filled with orange bottles, just like this. I had a gallon Ziploc bag full of these, and I would take the bus to school. And every single day on the bus, I would open it up and take all these medications. I would just get all these looks on the bus, like, who is that guy? And why is it every day he's got six, seven, eight of these that he pulls out to take? And I look like a sick man walking around. And it's you just at some point, I turned a bit into a shell of myself because I hadn't really found a new identity. I'd only poured myself into sports a good chunk of my life. This was my thing, and now that's all gone. I don't know who I am. I don't know what's my mission and statement in life. Where am I headed? I'm not sure. But at some point in this limbo period, as I'm getting more and more ill, I find filmmaking. It's something that I always thought was interesting. I used to do this thing where I'd watch the bloopers to movies with my mom when I was younger. I always watched the bloopers to the movie Rush Hour. I thought it was amazing. I thought it was so funny. And I thought that always looked interesting to me. So I decided to pick it up and it kind of became my life. And I found this new thing. And I start working in the film industry and I'd working there for a couple of years and my kidney disease is getting worse. I'm now pushing over 300 pounds. And at this point, it's all water weight, or at least I believe it is because the weight is gaining so quickly. My skin has stretched. My body looks physically different. I don't recognize myself in the mirror anymore. But I'm spending all my time on film sets going, I'm going to direct movies one day. And at the same time, I'm desiring this thing, I'm wrestling with my mortality. And I'm realizing as I get sicker and sicker, I accept that this is just how I live now. And I think this is just my quality of life. And at some point, when you live such a poor quality of life for so long, it just feels completely normal to you. And to me, it's just normal. And I feel uncomfortable every day, but I'm excited to get to a film set because that's the only thing that's really keeping my head above water. And one day, I'm in New York, I'm on a film set, and it's nighttime and it's snowing. And I had just had a meeting with my doctor like a month earlier. And he said, listen, you're at stage 4 now. And I just want to prepare you for some things. If you get to stage 5, if your kidney function drops below to 15%, you're going to have to go on dialysis. And at this point, I don't really understand dialysis in totality, but it feels like it is the end. Like I think death is around the corner somehow. And I am taking this information and putting it way in the back of my mind so I don't have to think about it. And I just go, I'm going to keep moving forward and not think about this. And he told me something specific. If you feel a metallic taste in your mouth, I want you to come to me immediately because they're going to have to put you on dialysis. I was absolutely terrified of this idea. And I didn't tell him, but I did taste it a couple days after he told me that. And I refused to tell him because I did not want to know what dialysis entailed. And I went on for weeks as my kidney function dropped below 15% without telling my doctor. And, I'm on this film. So getting back to me on this film set, it's snowing and I believe I catch a cold and I'm sniffling and I'm like, no, when you've got something stuck in your throat and it just won't go away. And I get home thinking, man, I can't wait to rest because I feel terrible. And I lay down in my bed when I finally get back to New Jersey where I'm staying with my family. And this thing feeling won't go away. It's like can't like it's like and the only relief I have is when I sit up. And my dad looks at me and he just goes, something about this kid is not right. And he looks at me and as he's looking at me, he calls his sister and goes, there's something wrong with Destin, and I don't know exactly what it is. And he goes, he's real quiet. And my aunt goes, when have you ever known Destin to be quiet? And he goes, you're right. And he hangs up immediately and goes, come on, we're going to the emergency room. So we go to the emergency room. And I had been to the emergency room at this point so many times. The people there know me. I am now, by the way, I'm 25 at this point. This is a story that went over the course of 6 years. And I told them, I called my nephrologist. He's the one who actually said, when I was on the way to the ER, he said, okay, no problem. I'll meet you there. And we went to Robert Wood Johnson in New Brunswick, New Jersey, about 3 miles from my family's home. And we tell them what's going on. And my nephrologist calls ahead. By the time I get there, they already know what's going on. So they have a cot for me, or they didn't really have a cot for me there. But when I got there, they looked at me and admitted me straight away. They didn't even ask that many questions. I don't know what they saw, but they knew something was wrong. They admitted me straight away. They ran all these tests on me very, very quickly. They took my blood pressure, and a doctor comes in and goes, listen, your blood pressure is through the roof. It is well into the 200s. So, and your heart shouldn't be beating this fast. And they gave me something called nitro paste, and they put it on my chest, and they said, this is going to drop your heart rate almost immediately because you are in heart attack zone. I had no clue. After they run these tests, the feeling that I was feeling was I was drowning because water was getting into my lungs. I had no clue. I just thought I was just, I had a cold. I had phlegm in my throat, and it wasn't it. And they put me on emergency dialysis. They took me to this room, and they put this PICC line in my neck, and they said, don't move. We're going to put you on this table. It has to happen immediately. And I've never been in a situation that was so immediate. And I've been in emergency rooms plenty of times before I've had before I was diagnosed with FSGS. When I was younger, I had a childhood asthma. I almost once cut my finger off. I was always in an emergency room for something, always sick with something. I had about 4 healthy years in my life, 4 purely nothing was wrong with me, healthy years. And they lay me on this cold table, and it's happening so fast. And they come with all these nurses and all these doctors. And the doctor looks at me and says, don't move. We're going to put some anesthesia in, but we can't really put you to sleep. And they stick this incredibly intimidating needle, and it was not small. I'm talking like bigger than my finger in the side of my neck. And that anesthesia is not helping. And I keep twitching and moving, and they go, you gotta stay still. And they finally get it in, and they've got what looks like a port in my neck. And they use it for dialysis at some point. But after they put it in, they just left me there on that table for some other doctor to come in. And for a few moments, I was laying with myself like an hour ago. I just came to the ER, and now I've got this thing in the side of my neck, and I don't really know what's going on. I don't know what's happening with dialysis. Why am I at stage 5? How did this begin? I still don't have answers, and it's been 6 years, and I'm laying on this cold table just crying to myself, thinking like, what's happening? And I'm too scared to ask any questions. They're talking to me, but it's just falling on deaf ears. And they put me on dialysis. My nephrologist finally gets there, and he tells him what's going on. He goes, you're going to go on dialysis. You're going to go on this machine. It's going to clean your blood for you manually because your kidneys are no longer working. So this machine is going to take the place of your kidneys. At this point, I'm 318 pounds. They put me on dialysis back to back for 3 days straight. By the time I was done, I was 218 pounds. I had no clue I had gained 100 pounds in water weight over the course of 6 years. I looked completely different. And they took me to this dialysis center after 3 days. They said, listen, this is something you can't miss. This is emergency dialysis. It doesn't normally go this way. Normally, what you would do is we would take you to this dialysis center every morning, and we would run through this process. It lasts about 5 hours. For me, it was 5 hours. And it'll clean your blood for you every day. You can't ever miss a day. By the time they had tested my kidney function, I think I was at like 7%. Too afraid to tell my doctor I had already blown past the 15% he warned me about. When I had met with him, I was around 23%. So now I'm got this thing in my neck. They give me another port in my chest right here. They take this one out eventually. They send me to this dialysis center with a completely new set of nurses that I don't know. I can't really take change right now. And they say, you can't miss this. You must come every single day. And the manager of that site made sure to drill that into my head. And it just scared me even more. And I eventually, I go there for a year every single day. I'm not allowed to miss this. And they said, we got to get this transplant process started. And for the first 6 months, I didn't do anything about it because I was so deep in a depression. I did not look at the idea of a transplant. I had all this family around me willing to give me a kidney, and I couldn't start the process. And eventually I did. And they said, listen, ideally it's someone related to you because their genetics actually match who you are. And my mother stepped up and said, I'll give him a kidney. And the doctor said, oh, we got to talk about this. She goes, nope, let's get the show on the road. This kid has been on dialysis for a year. I've seen him be sick for 6 years previous to this. Let's get this show on the road. And they did all this testing. And they said, you know what? We'd love to give you, your son, your kidney, but we have a better idea. We've got someone else at this hospital. And at this time, we're no longer at Robert Wood Johnson. We're at a completely different hospital in New Jersey. It was the best transplant department in New Jersey. And they said, we have someone else here. We have someone who's Destin's age who wants to give their mother a kidney. So what we want to do is we want to swap you guys so everyone has an age appropriate kidney. So I received a kidney from someone in Ohio, and she ended up giving and my mom's kidney went to her mother. I received that by the time I was 26, and they monitored me very closely after that to make sure the FSGS doesn't return, and they let me know it's a possibility it can attack the transplanted kidney. It has been 6 years since then, 7 years this November, that I have received a transplant from my mom. And even never understanding what was really going on, I didn't really understand the weight of all of it until about 2 to 3 years ago. And I was sitting in my driveway and it finally hit me. I was this close to dying. And like, oh, emergency dialysis is not a joke. FSGS is so much more serious than I thought. I was so busy trying to escape the reality of what was happening. And the truth is, when the reasons I was escaping it isn't just because I'm avoidant, but because I didn't have the answers. I was looking away from a thing I didn't know. And no matter how many questions I did ask, it only left me with more questions. And I said, I just want to, I'd rather look away and try and look forward as long as I can before this thing comes for me. And I don't know when it's going to come for me. I don't know how it's going to come for me. I don't know the who, what, when, where, why, how, if anything. All I know is I'm feeling worse and I don't want to deal with it. And, at some point, the end stage kidney disease got to me. And it was just an incredibly traumatic experience. And I look back on it realizing no matter what my nephrologist told me, he himself never knew enough. He eventually sent me to another doctor named Dr. Gerald Appel at Columbia, who was the leading man on FSGS at the time. He took me off all the medications my original nephrologist gave me, put me on a completely new medication called cyclosporin. And to be frank, that didn't really help either. The most helpful thing that felt good was getting off of all the previous medications. And now I'm on a pretty minimal amount of anti-rejection meds. And they said, you got to take these every single day for the rest of your life. I said, I don't mind. This is a great deal. These medications every 12 hours, big thumbs up. Because honestly, the moment I got that transplant, within moments of waking up out of that surgery, I felt better. And an hour after waking up, I felt twice as good. And 2 hours after that, I felt 10 times better. My kidneys were working. I couldn't believe I had been living that quality of life for so long that when I finally got back to a normal quality of life, I couldn't believe that this is what I was missing. That's what I was missing. I was living on the edge for a long time. And so, years later, here I am in front of you all telling you how I got here and, telling you all the patient perspective of what it's like to experience FSGS, especially at a time where people understood it far less. But, that's my story. And I really hope that is something that the community can really, pick apart and take away from so that we can help move, our community forward in terms of research.
Yeah. So thank you, Destin. That was, first of all, I'm sorry when you get to see the video, but your story and the way that you just explained it, leaves so many impacts. And I'm thankful that things for you because the transplant are working well. A few things that you said, though, I want to leave folks with was that even with when you live with FSGS, and even when you get a transplant, recurrence is a real possibility. And from what I gather, sometimes as much as 60% of the time, so that's another variable to this. The other takeaway that I got from you was the lack of awareness, not just from you as an individual, but also from nephrologists that you were seeing in the system. And so I think that a lot of what this whole webinar is about raising that awareness, not just with people who are at risk, not just people who've been diagnosed, but with people who are treating patients who may have FSGS and they may see a test result and think, oh, that's just hypertension, or that's just this or that, and to really jump on it early on. So thank you for that. I'm sorry that we couldn't play your video, or if you have it, no, it's okay. All right.
I do have it ready whenever the opportunity comes, if it comes today. I know it was
Okay. Well, so Matt, do you mind? Can we play it? Are you okay with that?
Perfectly fine. I just would say make sure to click that button that allows you to, when you share your screen, also share the sound, because that's probably what it was.
Oh, that's what it was. Yeah. So we'll give it one more go. If it doesn't go, then Matt, we're gonna hand it to you. So sorry. Thanks, Matt, for being flexible. We can't hear you. We can't hear it. No. Mm-mm. Uh-uh. All right. Well, we gave it a go. Okay. I think we're gonna move on if anybody can hear me. Matt, can you hear me?
Yes, I can.
All right. I think we should just move on because I don't think that I can't hear the video and I want to make sure that the audience has time to hear what you have to say. So let's just move on, Dane, if we can do that, or Destin. Yeah. Yeah, I think Destin, I think we're gonna move on because yeah, I just want to make sure that Matt has his time. So Matt, sorry. So
No
Okay.
Matt,
problem. You got it.
yep. So Matt, sorry, thank you for being patient. And Destin, well, maybe we can get the link out to the audience after the webinar is over and they can watch it at a different time. But Matt, Matt, you're at NFCure. I feel like your organization is obviously on the front line of this and pushing hard on behalf of all individuals living with FSGS and other rare kidney diseases, but also people who are at risk for it. And you're doing a great job, your organization, around raising awareness to the folks who are making laws and passing policy that affect the folks who are dealing with this and are at risk for this. So I'm going to defer to you and hand the floor to you because you're a political, I feel like, genius. And so, if you could just share with the audience what's happening right now in this very interesting climate and what you're seeing and what you think folks should be aware of in terms of how they can advocate.
Absolutely, and thank you so much for the opportunity. So for those who don't know, NFCure is a rare kidney disease patient advocacy organization. We focus on all rare kidney diseases, although FSGS is very close to our heart because our organization was initially founded by parents of those who suffered with FSGS. So we were extremely excited with the approval of FILSPARI to treat not only IgAN, which is another rare kidney disease, but also FSGS. It's the first FDA approved treatment for FSGS. And, both Dr. Hall and Destin really hit on a lot of the major points that, we try to work on in our policy, particularly with a bill that we have called the New Era of Preventing End-Stage Kidney Disease Act, or New Era for short, which is first and foremost getting more research out there because there is just a lot that is not known about rare kidney diseases in general. A lot of times, and kind of there's a broader term called chronic kidney disease, which obviously is the kind of traditional kidney disease that people think of. Oh, I have diabetes, I have hypertension, I have some other medical disease or something that is affecting me that because of that, my kidneys are also failing or I'm getting kidney disease from that. With rare kidney diseases like FSGS, they come out of nowhere. They hit people, who are young, in shape. Destin talked about it. He's training to be a pro tennis player. Some of the most famous people who have rare kidney diseases who are athletes who clearly are not, they're taking care of themselves. They're taking care of themselves better than most people are. And so, it is something that we really try to work to first of all, figure out how does this happen because there is no clear-cut reason as to why someone gets FSGS or gets IgAN or any of the 150 known rare kidney diseases. So getting more research there is first and foremost. And in the New Era Act, the first section focuses on creating centers of excellence for rare kidney disease research, so that in conjunction with the NIH and public and private partners, we can actually figure out and try to hopefully mitigate these diseases before they really get to end stage or get into those later stages. Because I believe as Dr. Hall said, that the sooner you get diagnosed, the sooner you can start treating it. Because once your kidneys are scarred, there's really no way to cure them or fix them. So it is something that you really have to get. You have to be able to treat those diseases as soon as possible. Preventative care, upstream care is a big focus of our bill, the New Era Act. Another part of that Destin talked about is that nephrologists, the majority of them are not well trained in spotting rare kidney diseases. It's not that they're bad doctors by any means. It's just that the focus for basically since the 70s, when dialysis really became the go-to treatment for any kidney disease, people have just focused on that. So dialysis and transplant, which may work in other cases, but with rare kidney diseases, they are not the silver bullet. I mean, dialysis is not a cure. It is just sort of a stalling tactic until you get a new kidney. And as Destin mentioned, once you get a new kidney, particularly if you have a rare kidney disease, you can still get that disease can reoccur in that brand new kidney. So even though it's a healthy, obviously very healthy kidney that gets put into you, within 24 to 48 hours, you can start seeing FSGS reoccur in it. And so it's something where we want to work on that preventative care and that upstream care. And as Dr. Hall mentioned, with Filspari being uh, you know, now FDA approved for uh, FSGS, we have a treatment that's already been out on the market. This isn't a brand new drug by any means, but now patients can go to their doctors today, and if they have FSGS, they can talk to them about getting on Filspari, and so that's a huge part of that as well. The biggest things that our bill kind of, like I said, focuses on is more research and then more patient and provider education. The bill calls for having not only more nephrology fellowships for folks to be able to focus on these rare kidney diseases, but also teaching primary care physicians as well. They tend to be the first people that you see. Not many people go to a nephrologist when they're starting their diagnostic journey. They go to their local family doctor, their primary care physician, who can easily misdiagnose it. Again, not because they're bad doctors, but because they have maybe no or little experience when it comes to kidney issues, and so it's very easy to misdiagnose. And the longer that you're on that diagnostic journey, your kidneys continue to wear down over time. And with FSGS particularly, it's a very progressive disease, and you can get to end stage very, very fast. I mean, there's a term in the community called crashing into dialysis, and that's what it is that somebody, once they finally realize that they have a rare kidney disease, they are at the point where they need to go on dialysis right away, or else their kidneys are going to fail and they're going to die. So that's the big sort of where the policy landscape is right now. I would say that in terms, kidneys are getting a lot of attention. Actually, in President Trump's first term, in 2019, he had an executive order specifically on American kidney health. They really helped jumpstart a lot of research and clinical trials into treatments for kidney disease and rare kidney diseases as well. That the fact that Filspari is now not only on the market for not one but two different rare kidney disease is a real testament to the effect of that executive order. We of course are pushing for the New Era Act to get passed into law because we want to continue that work. And this administration has shown a real desire to really focus on and try to work on kidney related issues. And so I know there's been rumblings of another potential executive order from the administration as well. This one focused very much so on upstream care and preventative care, because it costs Medicare over almost $200 billion a year to treat kidney disease, and that's all kidney diseases at every level from end stage to stage one. And so that's a lot of money that the federal government's spending right now on this disease. It's I think the eighth leading cause of death in the United States. And, there are still people out there who have no idea that they have a kidney disease. And it's something where, educating patients, educating providers, and getting more research is really the first steps to ensure that we're getting more attention on this, and that people are able to, get diagnosed sooner, so that way they can get on treatments. Because now we finally are getting some of those treatments, and we want to make sure that they actually have access to them and are getting prescribed them.
Thanks, Matt. And one thing that you said was, the cost of just generally just kidney care to Medicare is in the hundreds of billions, but that's just Medicare. And what we talked about was that Arcady and FSGS, they put people when they're younger than being eligible. I know you get eligible if you're on dialysis, but for someone like Destin, who at 19 was diagnosed, so who knows the real total cost of what we're really talking about, and who knows what the real total savings are if we were able to sort of, raise awareness, get better screening, get better surveillance, and get people in the hands with the care that they need. Who knows the total cost that would be for the entire healthcare system, but also to individuals,
Oh, yes.
that folks can stay productive in the workforce, they can stay productive in their families, in their communities. It reduces, the burden on, folks who are taking care of a family member. I mean, the total savings are all around and yet to be quantified. But I think that we can sort of, sort of connect the dots and see
Ex
there's a real opportunity, and why not leverage it and take advantage of it. So
You're exactly right. We try very much to point to the fact that while you can't necessarily quantify how much money will be saved by, doing more research or having, more clinical trials, you can point to the fact that, look, like when someone gets sick, especially if they're a working age, they might have to be going to a dialysis center every day. And that is a very draining process for some folks. Some folks, surprisingly, they're more spry. Other people are not. Everything affects people differently. And then on top of that, if they need to have a caregiver, that's a family member or somebody who basically has to stop working or certainly has to reduce their hours in order to care for that person as well. So there is a really difficult to quantify, but very obvious upside to getting more people treated and taken care of. And I think also, the name of this, obviously this webinar is about National FSGS Awareness Day. And, we just had it this past week on the 9th, and we had 6 states have legislative resolutions acknowledging that. And I'm sure there's probably a couple governor's proclamations I'm not sure of as well, but that's part of the thing is getting people more aware of these diseases so that they can make sure to treat them because these, they might be called rare, but there's 150 different of them and they add up very quickly.
yeah, yeah, and I'm glad that you said that, because I've always said, and I think you've heard me say this, I hate that it's called a rare kidney disease, because in certain communities across, it's not that rare, but also in certain communities, it's anything but rare. We just don't realize it yet because the data isn't there, and hopefully it will come. So I know that we're like, it's been sort of a crazy agenda with flipping and flopping, and I appreciate it. I'm seeing some folks have questions. One thing I will say, there was someone who asked a question in terms of how this relates to disparities. I don't know if we have time to answer that, but there was a person who's asked a few times, and I don't want to ignore her because she's been on from the very beginning. So if there is a way to talk about how this relates to disparities, I mean, I think with FSGS we talked about is disproportionate impact on people of African, just Black Americans, people of African descent. You mentioned IgAN briefly. It's the same thing, but that's for people who are really of Asian descent. But those two conditions affect everybody. They just happen to affect some populations more disproportionately harder than others. But can you talk, Matt or Dustin, but probably Matt, because your camera's on, about what this will mean in the larger sort of disparity elimination fight as relates to kidney care and kidney health?
Absolutely. I mean, I think that you're exactly right that specifically amongst different communities, FSGS and IgAN and other rare kidneys affect them more. Like as Dr. Hall talked about it, there is this, you are predisposed if you have the APOL1 gene, which is, usually descended from people of West African descent. So, my family did not live in West Africa any time in their lives. So, I probably don't have the APOL1 gene, but somebody else might. And of course, having the gene doesn't guarantee that you get FSGS, but it certainly raises your risk for it. And so, in working with the disparity part of this, one of the things that we do in the bill is to call out genetic testing and to try to look into finding ways. And we even specifically mentioned the APOL1 gene as an example of ways that we can look to see, how is this being affected? Because, for example, in some Asian nations that do deal with IgAN on a much larger and since they're checking out their kids in schools, like kind of like the scoliosis test. For those, if you remember, I know I had to do one. It's something where
Japan does that. Japan tests started
yeah,
from birth. It's like it's just routine in Japan. So I mean,
exactly.
there's a
And
lot
so
of yeah.
looking in, that's one thing that we also try to push is that early screening, like checking for stuff, even if sometimes there can be a false positive with protein in the urine, which is usually a sign of kidney disease. But for us, we think it's a real way to start treating people and checking people. definitely within the African American community, we try very much to work with a lot of community actors, particularly churches who are very strong in the area. I know in Philadelphia, for example, we have a very strong base because that's where we're originally based out of. Now we're fully remote, but we try to have folks get tested and checked out because it can be easy to put your head in the sand. Other times it's just easy to say, "Hey, I'm too busy to get a test right now." But these small things can really save you in the long run. Being able to, know your medical history and be sure that you're getting tested for the right things and being able to know, what your health is.
Thanks. And Destin, you clicked on. I assume you have something to say about this too.
Yeah, no, that like for me, I was the only person in my family who had a kidney disease, and it didn't seem like anyone else. I thought I had mine strictly due to what I was told was I when I got that cold coming out the pool. Sometimes, when you get a viral infection like that, it's very possible that your white blood cells from trying to help you might accidentally attack an organ, and a lot of the time it's your kidney. But the truth is that when I spoke to the VP of patient advocacy at Travere, she was saying, you don't know, you could easily be carrying, something inside of you that your whole family might have and you don't know, and because there's hasn't been any genetic testing. So I'm in complete agreement that genetic testing needs to be done throughout the community because a lot of us are walking around with hypertension, not realizing that it's actually something much deeper. And we kind of go our whole lives not realizing that there is something much stronger that's at play here that could be, handled much earlier if we're just aware enough.
So, the one thing that's come up a couple times is genetic testing, and it's great. There's all these advancements. I'm with it. However, they're expensive, and they're cost prohibitive. So that's one variable. Second one is, there's a lack of awareness about what those results be used for, who's going to have access to that data. But the biggest hurdle is that they're expensive. So for folks who are looking at this, who are hearing this, who are like, hey, I might be in the at-risk category, but I can't afford genetic testing. What are the alternatives? And also, nephrologist, it's for the layperson, you have to go through layers to get a referral to a nephrologist, right? So not everybody has a phone. They can go, hey, Dr. Hall, hey, how's it doing? You got to start at a lower level. So what would you recommend for folks who are listening? Like what would be your steps, for folks who want to be proactive, not just in becoming informed about FSGS and other rare kidney diseases, but in terms of taking it to their dinner table and figure out a strategy to make sure that their families are okay when it relates to some of these things that are a little bit less accessible to individuals when you actually try to access them.
Well, I will say that you're totally right. Genetic testing is very expensive at this point. It is not something that is commonly prescribed by a doctor, so it's not something that insurance traditionally covers. There are probably cases that, but if you just went to your doctor and said, "Hey, I want to genetic test myself to see if I got any diseases," they're going to be like, "That's crazy. You don't want to do that because you're going to be spending out of pocket." And so it is something that I think probably the biggest thing that I would recommend for folks is talking with your primary care physician. Again, like, your primary care physician obviously knows you probably better than most, and you can talk to them and be like, hey, I have been, they probably don't like saying it, but my wife always says, I've been talking to Dr. Google and he's telling me this. And so, doing some of the research yourself, it's out there. There are trusted sites like NephCure, like MMQF, where we're putting out real information and something that you can talk to your primary care physician about. Because if you suspect it or you think there might be an issue with your kidney, you got to speak up because as I said, it can be easily misdiagnosed as something else. We hear many horror stories of folks who were told, "Oh, it's allergies. Oh, it's stress. Oh," I had one person told me like they were told they had cancer. That something crazy like that. And so it is very easy for doctors to see something and be like, "Oh, it's this," and they just go down that rabbit hole and they don't think to look at other things or like, well, these symptoms seem similar to something else. And so talking with your primary care physician, just bringing something up, especially if you suspect it. And, if you think you might have a family, if maybe you've had family members who've also had kidney issues of some sort, or, a great aunt or something like, it's just there's something out there. ask your doctor, talk to him about it. I'll give an example myself. My uncle has hemophilia, which is a blood clotting disorder. And my daughter this week, unfortunately, had a little bruise on her foot and it just didn't seem to stop bleeding. So when I went to the doctor, I said, look, I don't think I have this, but is there any chance that, that this could be I passed this to my daughter? And, they said, they obviously gave me the history on it and everything, but it's something where bring that up to your physician, start that conversation. It might, it is the best way is to really talk to folks and figure this stuff out is talking to your doctor, but being open, being honest, being vulnerable. I know it's hard, it's not easy, but sometimes you got to do that in order to get answers for yourself.
Yeah, and I'm so happy that you share that, Matt. And not because of what you went through, but because at NFQF, Dr. Cochran has talked a lot about what he calls the patient signal, right? Which is you as a person listening to your body, and then your body doing what it does with biology, and then how the healthcare system responds to those signals. And this is a great example of what you're just saying, because you can sit here and Destiny, you talked about it, saying, hey, something's wrong with me, this isn't normal, I don't feel right, something's going on. Then you go through and you're accumulating water, you're gaining weight, things are falling apart, but the system is responding to you saying, oh no, this is what it is. So finding that connection between the patient's signal and the larger system, I think also is an important part of what we're talking about, and an important part of what's going to be required to really advance better care for folks with FSGS, folks at risk for FSGS and other RKDs, right? Especially as the treatment pipeline and the treatment sort of climate meets these diseases where they are. So you have accessibility, or you've got products or medicines or drugs that can be helpful. Then you've got these signals that are being ignored, and the system is not sort of connecting folks to what they need. So I think this conversation is really important for folks to sort of realize the value of being an advocate for yourself, being an advocate, with your families, but also speaking up when you're in a clinical setting, because when something's going on, sometimes that's the most important part of solving the problem. So I don't know, Dustin, I'm sorry if you wanted to say something. I know I jumped in. No. All right. So I think that's all. I don't really have any other questions that are coming in. I know we're a little bit over time. So I want to thank the two of you. Dr. Hall, I know I had to hop off because he actually had to go see a patient. And thank you for everybody who joined us today. And I think this is going to be posted at some point. If you have any questions, you can reach out to me if you want questions, or if you have questions of Matthew or Destin or Dr. Hall. I'll ensure to connect you with them. And with that being said, have a great Friday and a great weekend, everybody. Thank you.
Thank you
It's
so
been a
much.
pleasure.
Bye.